Good morning. Welcome back to Open Med School. I am Dr. Andrews, Professor of Medicine and Consultant Neurologist. Today I am going to discuss with you Internal Medicine Competency 9.1 Anemia. I will define, describe and classify anemia based on red blood cell size and reticulocyte count, and finally give a case and analyze how you can come to a morphological diagnosis based on the MCV and also on the reticulocyte count. The term anemia came from Greek word meaning lack of blood. So this is the meaning of the term. So when you say anemia, you have to determine what is anemia. Anemia is usually defined by the level of hemoglobin or hematocrit or the RBC count. But routine practice, it is a hemoglobin or hematocrit which is used for diagnosis. So here you can see you can grade the anemia depending upon the hemoglobin level. Normal, easy to take it as more than 12 grams. Depending upon the age and sex, there is difference is there, but conventionally you can take more than 12 as normal. We say mild anemia when the hemoglobin is between 10 and 12 grams, and moderate it is between 8 and 10, and severe anemia when it is less than 8, and life-threatening anemia when the hemoglobin is less than 6.5. There can be mild variation from textbook to textbook. So minimum thing to remember, normal should be more than 12 grams, and mild anemia is between 10 to 12 grams, and moderate anemia 8 to 10 grams, and severe anemia less than 8 grams. When you look at the hands, if the palmar creases are same color of that of the palm, you can say that hemoglobin is usually less than 8 grams. The next step in the diagnosis of anemia is by looking into the size of the RBC, and that is the mean corpuscular volume. So MCV is the size of the RBC. When it is increased, it is called macrocytic RBC. When it is decreased, it is called microcytic. So morphologically, anemia can be classified into microcytic anemia, normocytic anemia, and macrocytic anemia. There is one more term you should remember is the mean corpuscular hemoglobin concentration. So this means the average hemoglobin concentration in RBC. That is the mean corpuscular hemoglobin concentration, the average amount of hemoglobin. Whenever there is phagocytosis, you get a increase in mean corpuscular hemoglobin concentration. So the condition that produces increase in mean hemoglobin concentration is the spherocytosis. It will be decrease in thalassemia, iron deficiency anemia, and in macrocytic anemia. So hope this point is clear. That is, in spherocytosis you get a increase in mean corpuscular hemoglobin concentration. In other anemias, usually the mean corpuscular hemoglobin concentration is decreased. We have already mentioned the anemias are divided into microcytic anemia depending upon the MCV less than 80 femtoliters. The most common cause is iron deficiency anemia, thalassemia, and anemia due to chronic disease, and sideroblastic anemia can also produce microcytic anemia. So what are the common causes of microcytic anemia? Number one is iron deficiency, second is, remember, thalassemia, third anemia of chronic disease sometimes, and sideroblastic anemia. Then we come to the macrocytic anemia. When the mean MCV is more than 100, you can say it is macrocytic anemia. The most common causes are B12 deficiency, folic acid deficiency, in alcoholism, liver disease, sometimes in myelodysplastic syndromes. Certain drugs like sidovidin and hypothyroidism can also produce. So macrocytic anemia, classically the most common cause is B12 folic acid deficiency. In alcoholic patients you can get, in hypothyroidism you can get, as mentioned in myelodysplastic syndrome also we can get this. Now we go to the normocytic anemia, sometimes called normochromic anemia. Here the MCV is 80 to 100 femtoliters, and the most common cause or causes are, one is bone marrow is suppressed. When the bone marrow is suppressed, the RBC produced are of the same size, but the patient will be having anemia because the production is decreased. That is the reason for the aplastic anemia, and the aplastic anemia produces a normocytic anemia. And another condition is the myelodysplastic anemia, that is something is infiltrating the bone marrow and the production of cells are decreased, for example tuberculosis. Anemia of chronic disease is typically normocytic. So the most common cause of normocytic anemia that you will come across is anemia of the chronic disease, that is patients with renal disease, rheumatoid arthritis, tuberculosis, etc. can produce a normochromic anemia. Hope this point is clear to you. Now we go to the, always remember that different types of anemia can also occur in same patient. For example, early iron deficiency can lead on to normocytic anemia. So iron deficiency produces not only microcytic anemia, in a mild iron deficiency you get a normocytic anemia. And chronic anemia or anemia of chronic diseases can also be normocytic, but sometimes you get microcytic too. So patient can have, a patient with a chronic anemia or chronic disease can be a normocytic anemia, or it can be microcytic anemia also. It is because the iron utilization is defective. The availability of iron, we'll explain this later. Hemolytic anemia typically cause macrocytic anemia, but you can get normocytic anemia also. So this morphological classification is not absolute. So different types of anemia due to single cause. For example, as mentioned earlier, iron deficiency can lead on to either normocytic anemia or microcytic anemia. Or a patient with a chronic kidney disease can have a normocytic or can be microcytic anemia also. Hope this point is clear to you. Now the next important point to remember in patients with anemia is what is the production of RBC. Okay. The lifespan of RBC is approximately 120 days, and 1% of RBCs are destroyed daily. If there is an imbalance between this, that is production is decreased or loss is increased, we can get anemia. So here we utilize what is the number of young cells, that is reticulocytes in the blood. So we'll think about what is reticulocyte count and corrected reticulocyte count. The reticulocyte count corrected for the hematocrit or hemoglobin is called the corrected reticulocyte count. That is, a patient you calculate the reticulocyte count, count in percentage, and you give a correction for the patient's hemoglobin. That is, hemoglobin of the patient divided by the normal hemoglobin. That is, if you take it as 15. Either you can take the hemoglobin or you can take the hematocrit. If it is hematocrit, you take the average hematocrit as 45 normal. So this is what is called the corrected reticulocyte count. Hope this point is clear. There is reticulocyte count percentage. There is a correction is given for the reduced hemoglobin or hematocrit. Reticulocyte count multiplied by the hemoglobin of the patient divided by normal hemoglobin or hematocrit. It is called a corrected reticulocyte count. Basically, you can think that when it is more than 2%, the production is adequate or accelerated. So anemia with a corrected reticulocyte count more than 2% suggests the RBCs are being produced at an accelerated rate. Hope it is clear to you. There is one more terminology you should remember is the reticulocyte production index. It is called RPI. That is reticulocyte production index, RPI. Should remember that when there is anemia, the younger cells, that is the reticulocytes, are released from the bone marrow early. Even within 1 day, it is released to the peripheral blood. And so you have to do a correction for this. That is called a maturation correction. Here what is being done is, for each hematocrit, the values are different. You divide the corrected reticulocyte count. So the corrected reticulocyte count, divided by maturation factor. If the hematocrit is 35 to 45, it is 1. So it will be same. If it is less than 15, you have to divide with 2.5. So depending upon the level of hemoglobin or hematocrit, you make a correction for that and for calculating RPA. So what is reticulocyte production index? The reduction, many people take 3 as the cutoff value. RPA more than 3 suggests normal bone marrow response to anemia, and less than 2 suggests inadequate response. For you, hope this point is clear to you. So you are correcting 2 levels, one for the hemoglobin and second is for the, next is you do a maturation correction. And a RPA of 3 means there is proper response. Less than 2 suggests it is hypoproliferation. Hypoproliferation. If you can't remember this much, you just remember the stop at the level of corrected reticulocyte count. That is reticulocyte percentage into hemoglobin of the patient divided by normal hemoglobin. If it is more than 2, we can say that the bone marrow is responding. There is a proliferation is going on. So this is the basic level you should remember. So we have mentioned what is corrected reticulocyte count. Now we go to a patient. This is a history of a 35-year-old female where presenting complaint was general weakness and fatigability for the last several months. So the common complaints, as you know, is a fatigue, weakness, and shortness of breath, cold extremities, etc. And her past medical history, there is no significant medical history, no drug intake, but she had heavy menstrual bleeding. She is a vegetarian. Vegetarians are more prone for B12 deficiency. A detailed menstrual history is to be taken. There is no family history. There is mother had iron deficiency anemia. There is no one in the family is having any significant anemia or any problem. She is in the social history, she is a non-smoker, no history of alcohol or drug use. She is vegetarian for the last. Any vegetarian, there is increased chance of B12 deficiency. So you should go for a detailed history, then do a general examination. A general examination revealed pallor of the conjunctiva. There was no jaundice. Oral examination was showing pallor. CVS showed tachycardia. As usual, anemia produces a hyperdynamic circulation. There is no lymphadenopathy. Lymphadenopathy is common in leukemia, etc. Abdominal examination should look for spleen. There was no splenomegaly. So this is the routine thing that you do in a patient with anemia. Then we go for the basic investigations. Hemoglobin is 8.5. So you can say the hemoglobin is between 8 to 10. So it is patient has got a moderate anemia. MCV is 65. It is less than 80. So you can say the patient has got a microcytic anemia. So it is a classical microcytic anemia. So what are the common causes for microcytic anemia? Microcytic anemia, the most common cause is iron deficiency, thalassemia, anemia of chronic diseases, and sideroblastic anemia. Here a patient with heavy menstrual bleeding, it is more likely to be iron deficiency. So next we go for the reticulocyte count. The reticulocyte count correct is 1%. That means there is a proliferation or there is a hypoproliferative anemia. Nutrition anemia leads on to hypoproliferation. Then next we go for the iron studies, serum iron, total iron binding capacity, and ferritin. Obviously the most important at this level we'll think about the ferritin. A ferritin level less than 13 definitely means it is iron deficiency. So as is a vegetarian, you can go for the B12 level. So B12 level is 400. So folate level also can be estimated. So this patient has got a microcytic anemia. And from the history and findings, the most likely this patient is having iron deficiency anemia. So now we come to the morphological diagnosis. This patient is having microcytic anemia as evidenced by the MCV, that is 65 femtoliter. In addition, we have found that the corrected reticulocyte count is 1%, that is less than 2. 2 means there is inadequate response from the bone marrow. If we want to calculate the RPI, that is reticulocyte production index, here is not required. You have to divide the corrected reticulocyte count, that is 1, by the maturation factor. Maturation factor for a hematocrit of 25 to 35 is 1.5. So 1 by 1.5. Of course, it becomes less than 1. And when the RPI is less than 2, we can definitely say that the patient is not, the bone marrow is not responding properly. So this is an example of hypoproliferative anemia. And nutritional anemia can, like iron deficiency, can produce a hypoproliferative anemia. So this is a microcytic anemia with hypoproliferation, and most likely cause in this patient is iron deficiency because the serum ferritin is less than 13. Hope it is clear to you.